Good day, everyone. I'm Su Chin. I'm a medical oncologist. I'm from the Department of Hematology Oncology at National University Cancer Institute, Singapore. Actually, I have a co-chair who is a surgical oncologist, Professor Michael Hartman, but unfortunately, he has an emergency case to attend to this morning, so I will be chairing this session. So I'm very happy to be chairing this morning's session, which is plenary session 1 of this NCIS Surgical Oncology Symposium 2021. And we are very privileged to have two distinguished speakers, both from the United States, in this session. I'm going to touch on two very important topics. The one is on the state of art surgical oncology, and also on the importance of benchmarking and quality assurance in surgical oncology. And our two distinguished speakers this morning in this plenary session are Professor David Bartlett and Professor Timothy Pollock. We will have each of the speakers will be speaking, and thereafter there will be opportunities for Q&A. So we do encourage the participants to log in your questions online. So I'm going to introduce the first speaker, who is Professor David Bartlett. He's currently chair of the AHN Cancer Institute, and he's an internationally recognized cancer surgeon and a pioneer in abdominal cancer treatment. He was the past president of the Society of Surgical Oncology, and he served as senior investigator in the surgery division of the Center of Cancer Research at the National Cancer Institute, where he developed innovative surgical techniques to treat patients with abdominal and liver cancers, as well as performed cutting-edge lab research in viral-based immune therapies. His medical degree was from the University of Texas Medical School in Houston. He did surgical residency at the Hospital of the University of Pennsylvania in Philadelphia, and then went on to do a surgical oncology fellowship at Memorial Sloan Kettering Cancer Center in New York, and a research fellowships in MD Anderson, as well as at the Hospital of University of Pennsylvania. He has been consistently chosen as one of Pittsburgh's best doctors every year since 2006, and he has had more than 300 research papers and more than 40 book chapters. So let's hear from Professor David Bartlett.
At the first NCIS Surgical Oncology Symposium. It's an honor to be included in this program, and very excited to be here. I wish, obviously, that I was there in person, and I really enjoyed previous visits to your beautiful country, and hope that I have the opportunity again to do that in the future. But it is great that we can do it this way, and that I can speak to you all from Pittsburgh, Pennsylvania here, and the Allegheny Health Network Cancer Institute. And the topic of my talk is state of the art for surgical oncology. I am a past president of the Society of Surgical Oncology here in the United States, and have really thought a lot about what a surgical oncologist is, what we should be, and what should our goals be for the future. And hopefully that will be helpful for you as you grow as a program in society. So I look back when the Society of Surgical Oncology was kind of being organized, and this is the first edition of the Annals of Surgical Oncology. And Charles Balch, who is the founding editor of the Annals of Surgical Oncology here in the United States, wrote an editorial about what is a surgical oncologist, and he provided a synthesis of viewpoints from all of the well-known surgical oncologists of the time to kind of put together a summary of what is a surgical oncologist. And this is a nice editorial if you get a chance to look at it. And I've just created a few of the bullet points here that I think highlight what a surgical oncologist is. Somebody that has an extensive knowledge of the disease process, the potential therapies available, and the ability to guide the patient appropriately with the best combination and sequence of cancer treatments. The surgical oncologist really takes responsibility for the patient and that patient's cancer care from start to finish, being involved in all aspects of decision-making related to that cancer. And you know, that's just, we are that patient's oncologist throughout their care. They have to be a competent technical surgeon as well as a skilled oncologist, has the knowledge and judgment to safely apply surgical treatment options, ranging from conservative to the radical in individual patients based on the biology of their disease. So it's extremely important for surgeons to understand the biology of cancer and therefore understand what decisions can be made and when it's appropriate to apply surgical treatment. provide institutional leadership in cancer prevention, screening, and diagnosis. So it's not just about being a technician, but really about leadership and the overall knowledge of cancer care. And finally, able to coordinate multidisciplinary cancer care and be an effective partner on a multidisciplinary care team of oncologists from different specialties. Certainly here in the United States, the surgical oncologist is usually the one running the tumor boards and kind of managing the multidisciplinary care and is a leader in that regard. So to keep in mind as the roles for a surgical oncologist. And in the United States, surgical oncology is really the umbrella organization over surgical subspecialties related to cancer, endocrine, colorectal, breast, sarcoma, pancreas, melanoma, liver, peritoneal surface malignancies, GI, and research all fall under that umbrella of surgical oncology. But we really see surgical oncology as the overlying specialty. And so also important to keep in mind. Training in the United States, in case you're not familiar, it's 4 years of undergraduate, 4 years of medical school, and then 5 to 7 years of general surgery residency. I have to say that the surgical oncology fellowship programs have become one of the most competitive fellowships in the United States. And so it's almost imperative that anybody interested in surgical oncology does 1 to 2 years of research during their residency. So it extends your residency, but it allows you to be competitive and obtain a surgical oncology fellowship. So usually 7 years in the residency, 2 years of fellowship in this complex general surgical oncology, which is a boarded specialty in the United States, which was boarded in 2011. Then both qualifying written exams and certifying oral exams in surgical oncology, and then setting up practice either in an academic center or a cancer center. Right now we have 36 approved accredited fellowship programs in complex general surgical oncology in the United States and Canada, and we graduate 68 fellows each year. And you can see a variety of programs here. These are most of the academic programs, most of the well-known cancer centers within the United States have surgical oncology fellowship programs right alongside of medical oncology fellowship programs, as well as radiation oncology fellowship programs. And the Society of Surgical Oncology remains very strong. It's really seen as kind of the wisdom behind cancer care and cancer surgery. Now, there's greater than 3,000 members in the society with the mission to improve multidisciplinary patient care by advancing the science, education, and practice of cancer surgery worldwide. We do have an annual meeting which draws somewhere between 2,000 to 3,000 people. And unfortunately, that's been a virtual meeting for the last 2 years now, but hopefully at some point we'll be able to bring people together. And it does have quite an international following and really is kind of the hub of the society. And it's really a nice meeting. I would say that the surgical oncology community is known for its strong clinical activity. SSO members are represented in each of the 1,500 cancer centers across America and in the 49 National Cancer Institute designated comprehensive cancer centers. We represent experts in all cancer types, so it's not as if surgical oncologists don't subspecialize, because at most academic centers they will, within breast surgery, within pancreas surgery, liver surgery, and such. So there are subspecialization within surgical oncology, but surgical oncology is really the basis of what they are. Driving innovation in cancer care, robotics, regional chemotherapy, the management of lymph nodes, non-operative managements, these kind of innovations are important. And I'll talk a little more about where I think surgical oncology needs to move in the future. Leading the multidisciplinary team, also an important aspect that we think about. Strong research in surgical oncology. Cell-based immunotherapy is really born out of the National Cancer Institute and the effort by Steve Rosenberg, who's a well-known surgical oncologist in the United States, really developed CAR T therapy, TIL therapy, cell therapy in general for cancers. And I'm sure you're all familiar with this process, so I won't go into it. But suffice it to say that the research aspect is a really strong component of what identifies a surgical oncologist or part of the surgical oncology armamentarium. Very strong on education, educating medical students, residents, fellows around surgical oncology. Again, we have fellowships, we have the annual meeting, we have the Annals of Surgical Oncology, which has become a very well-known and high-impact journal in the United States. SOSAP, Society of the Surgical Oncology Self-Assessment Program. We have Expert Ed, we have webinars, and we have now review courses for our exams. And so a lot of effort goes into education within the Society of Surgical Oncology. And I would say perhaps when I look at other countries and kind of how different surgical societies have developed and look back at how strong surgical oncology is in the United States, a lot of it does center around the leaders. And these are just examples of our leaders in surgical oncology. And these leaders have really become leaders in surgery or were leaders in surgery along the way. And so really the strongest leaders in surgery in America were also the leaders in surgical oncology. And so I think that helped to strengthen the surgical oncology field within the United States. And on my presidential address for the Society of Surgical Oncology, I spoke about the surgical oncology moonshot. And so I thought I'd talk about that a little bit today to really review where we are and where we should be as surgical oncologists. What are the goals for the future? What should we be striving for as a group of surgeons? Because so many important findings in the past and in the future rely on surgical input and surgical research. So it's very important for us to think ahead and to be active and to continue to move forward in this regard. And I point to a concern of mine around the medical oncology field and others whose goal seems to be quite often to eliminate surgery as part of the care for cancer. And obviously that's not completely true, but I think the point is just that surgeons need to be at the forefront of cutting edge research in oncology in general and hold their place and really take responsibility for what we can do as surgeons. Because slowly but surely, things can and will evolve away from surgical treatment, and not always for the right reasons. And I won't go into it in detail, but I gave an example of gastric lymphoma, which when I studied gastric lymphoma at Memorial Sloan Kettering back in the 90s, early 90s, we found that the majority of patients, in fact, 95% of patients had 10-year cures from surgical excision of gastric lymphoma. And that's just not something that's even thought of anymore. And a much more complex regimen of multi-agent chemotherapy is utilized routinely. And the point being just that once we move away from surgical treatments, we will not move back, even in some cases where surgical treatment might be the best option overall for patients, least morbidity, fastest recovery, and better overall outcomes. So it's important for us to stay in the mix and really be at the forefront of cancer care. A couple of goals that I put together as part of where I think surgical oncology should be in the future. One is greater than 95% of patients undergoing surgery for primary cancers are cured. And so basically, the concept is that we need to do better with our surgical treatments to cure more patients. And some of that is around, adjuvant therapies and better adjuvant therapies. And this diagram kind of shows the different factors that I think are important. Improving adjuvant therapy, better prognostication through systems biology, machine learning, improving our biomarkers and our analysis of the tumor microenvironment. So all of this and the improved adjuvant therapy, and then finally managing perioperative factors that impact cancer recurrence. So this is where we as surgeons need to think and work in order to get to that goal of 95% of our patients are cured after surgery. And it's not an unrealistic goal, I don't think. All of these factors need to be taken into consideration, and we need to be at the forefront. When I think about just analyzing prognosis, we have so many ways that we can look at nutrition, genetics, radiology, the immune microenvironment, metabolism, cell division, comorbidities. All of these factors go into us defining prognosis. And there's so much more. There's predictive biomarkers. There's looking at DNA, RNA, enzymes, small chemical products, proteomics, what's going on in the cancer cell, looking at single cell RNA sequencing to really identify what's happening in the tumor microenvironment. What are the relationships of the immune cells to the tumor cells, and are they activated? Looking at cell-free DNA in the blood, apoptotic bodies, all kinds of things. All of this technology exists, microRNA-based biomarkers, looking at T cell repertoire analysis and what's happening with the T cells in the blood. So much of so much is out there right now that we can look at as predictive biomarkers, and surgeons need to be at the forefront of this. Why? Because we can draw the blood before surgery, we can draw the blood after surgery, we can analyze changes abruptly in the presence or after surgery. We need to be defining those patients that are cured after surgical resection and those that aren't cured and are going to fail and need additional therapy in order to impact their overall survival. So predictive biomarkers is extremely important, and it's all there in our hands. We just need to be utilizing all of this technology. We need to be directing those basic science, those proteomic experts, those genomic experts, and working with them to lead the effort into improving the care for these patients. This is a case report that I like to think about around the importance and the potential deleterious effects of surgery in the setting of cancer. So there's a patient that in November of 2005 underwent a low anterior resection for rectal cancer, received the usual adjuvant chemotherapy and radiation therapy at that time, and did fine for 12 years. And then we identified a local recurrence of his original cancer in the pelvis. And that's what you see here. So 12 years, he had a growing cancer in his pelvis, never metastasized, always localized regionally. And the patient was asymptomatic for 12 years, although became symptomatic there in July of 2017. So looking at it, realizing it was going to be a challenging case, but that we could achieve a complete resection, we performed a complete pelvic exenteration and complete resection of the tumor. It was complicated by a pelvic abscess and sepsis, and he was in the hospital for 20 days. But the kicker is that 25 new lung metastases were identified 2 months later, and you can see the slide here. And the patient succumbed to his lung metastases in less than a year. And this is just that thing that we all recognize, which is sometimes complicated surgery, stress, especially infectious complications, increase the growth rate of cancers, increase the ability of the cancer to spread. And whereas in 12 years, it did not spread, in a very short time after that surgical stress and systemic sepsis, the patient has diffuse lung metastases and succumbed. And I won't go into all the reasons for this, but there are a lot of reasons for this that have been well defined in the literature. And there are good randomized clinical trials looking at perioperative management to decrease the decrease the risk of cancer spread and acceleration of cancer growth as a result of that stress. And so, again, something that surgeons, surgical oncologists need to be at the forefront of this, because medical oncologists are not thinking about this. Radiation oncologists are not thinking about this. The only people that really can have an impact here are surgical oncologists. And it's such an interesting field to think about, so many moving parts. And something that only we can solve through innovative clinical trials around the time of surgical resection for cancer that really can have a profound impact long-term in cancer-related outcomes. And so surgical stress and complications, one aspect of how do we improve care for cancer patients? How do we get to that 95% cure? And then finally, how do we provide better adjuvant therapy? And as far as I'm concerned, as surgical oncologists, the majority of patients that we treat need to be enrolled in adjuvant clinical trials. And the adaptive trial design that Laura Esserman has really popularized through these I-SPY trials, where up to 5 new drugs are being looked at any one time in a randomized fashion against standard of care. So adding new drugs and then looking at the time of surgery at the complete response rate. So a very well-defined endpoint, new drugs in a randomized fashion. In a short period of time, we can say, are those drugs effective? Is that combination effective? With an endpoint that we all can sink our teeth into, complete pathologic response. We know complete pathologic response in any solid tumors corresponds to a better outcome. And so looking at neoadjuvant therapy, randomized trials, new drugs against standard, adding new drugs, and then analyzing for pathologic complete response as your endpoint. And for those regimens that improve pathologic complete response, fast-tracking those approvals so that we can move forward and add new drugs. So this is really where we need to be: adaptive designs, neoadjuvant trials, and assessing for rapid endpoints that can really allow us to move along. And in a short period of time, these are the drugs that have been, and the regimens that have been approved based on these adaptive designs. So, this will continue, and I think something that we should all be engaged with and involved with. And then there's the second goal. So the first goal, greater than 95% cure. So if we're taking someone to the operating room, we should cure them. The second goal is, how do we minimize the impact of surgery on cancer patients? And this gets back to a variety of things, but one is in multidisciplinary care, it's not just the surgery these days, right? It's neoadjuvant chemotherapy, it's postoperative adjuvant chemotherapy, it's radiation therapy. Patients get so knocked down by all these treatments that we can't knock them down more with surgery if we can avoid it. And we cannot, put somebody through an operation that takes 3 months to recover and then expect their cancer, especially if it's stage 3, stage 4, to have remained dormant, and if they can't get back onto chemotherapy. So really minimizing the impact of surgery is one of our goals, such that no operation has longer than a 48-hour stay is kind of our dream goal here. And I talk a lot about robotics. It's something I've been interested in for a long time. And in surgical oncology, we were behind the times for many years. This was something developed by minimally invasive surgeons, and really we weren't seeing the surgical oncologists embrace the minimally invasive techniques. And I think only really because of a lack of skill sets where we just hadn't trained our fellows in strong minimally invasive techniques. And so it was easy to make excuses why we shouldn't do this. And this is a robotic Whipple operation, something that that we worked on very carefully over many years at the University of Pittsburgh before I left, performing these operations in a streamlined fashion, educating our fellows as to how to perform these operations, looking at training modules, getting everybody facile with suturing techniques so that we could do complex surgeries with minimally invasive approaches. And the sky's the limit. I think, you know, we, as I'm sure is commonplace in Singapore, you know, minimally invasive Whipples, robotic liver resections, anything that is confined that we can help with a smaller insult to the patient, smaller incisions, easier recovery, less pain medication requirements, less ileus, and you know, shorter hospitalizations, all allows these patients to undergo more complex surgeries and still participate in multidisciplinary care. And interestingly, what we found was that you know, we could shorten the hospitalization a little bit. By a little bit, we're talking about less than 24 hours using minimally invasive approaches versus open approaches. But when we combined the minimally invasive approach with the ERAS protocols, that's when we got down to patients leaving in 4 days after a Whipple operation. But you know, my thinking is the minimally invasive surgery is just a small piece of what we need to have in place to really minimize the impact of our surgery on patients. So we need to educate the patients. We need to prehabilitate those patients that need it in terms of nutrition, in terms of activity, smoking, cessation, all of that. Perioperative care becomes extremely important. These ERAS protocols, which I know that you all are very familiar with, aggressive drain management, home care becomes quite important because we need close follow-up for these patients at home, and then telemedicine that allows that home care to be appropriately utilized. So all of this put together, we can get to a 48-hour stay for complex surgical oncology procedures. And that's just an arbitrary goal, but ultimately, if patients are only in the hospital for 48 hours, the impact of these operations are quite minimal compared to what we used to do. And then the goal number 3 is extending the role of surgical oncologists and extending it beyond just surgical resection and management of curative surgeries, but also how do we impact regionally confined metastatic disease as surgeons. And this is something that I started working on back at the National Cancer Institute in the mid-90s, and continued at the University of Pittsburgh, and have continued here at Allegheny Health Network. And something that a lot of surgical oncologists have really embraced and focused on from a research perspective, as well as a clinical perspective. So how do we extend our role? How do we make it so no patients die as a direct result of liver or peritoneal metastases? And these, as you know, tend to have a bad prognosis, but something as surgeons that we can consider ways that we can treat these patients. And we're familiar with hepatic arterial infusion pumps as an example, the combination of complex surgical resection for liver metastases and infusion of chemotherapy. We also worked very hard to study isolated hepatic perfusions, where we would circulate drugs through the liver at high concentrations. And that field kind of died out a little bit because of so many good systemic therapies for colorectal cancer. We did not use it so much anymore for colorectal cancer, mainly because of morbidity associated with these isolated hepatic perfusions, but we do still use it for ocular melanoma, uveal melanoma. And with new drugs and new trials, we could really focus on infusional therapies and regional perfusion of the liver as an example, and in combination with systemic therapies, in combination with local ablative and surgical resections. Likewise, peritoneal perfusions and abdominal treatments for peritoneal metastases is something that is utilized quite widely, and I know is utilized there in Singapore quite widely, with excellent research coming out of there. And so again, an example of where surgical oncologists really separate themselves by looking into how can we manage these complex situations, and really taking on these difficult patients and figuring out the best way to manage these patients through regional chemotherapy, regional delivery of heat, and a lot of other agents that may be effective in this way. And finally, limb perfusion. A lot of interest in the 90s around isolated limb perfusion for melanoma, for sarcoma. Not something that's used all that frequently in the United States anymore because, again, other options have come aboard. But that doesn't mean that there aren't still options where biologic therapies could be delivered regionally in order to achieve complete responses and really eliminate limb loss and radical surgeries for sarcoma and melanoma of the extremities. So these are areas where I think we really need to be at the forefront of research to come up with better treatments. And peritoneal surgery research has been something that I personally have been involved with and have a laboratory dedicated to. This is a picture of vaccinia virus, and I became very interested in oncolytic viruses back when I started my career at the National Cancer Institute, and created mutations in vaccinia virus in a very, very aggressive form of vaccinia virus, the WR strain, such that it would be selective at only replicating cancer cells, and then armed the vaccinia virus with a variety of immune agents to then induce immune response and get a secondary immune effect. So this idea of delivering live viruses into the peritoneal cavity has been utilized in clinical trials, and we have some new viruses that we're very excited about that we're in the process of applying to the FDA for approval for use in our peritoneal cancer patients. So, this field needs to continue to move forward. HIPEC has been great and a great option for many patients, but it's definitely not where we should be satisfied. We really need to move forward with better agents, more effective agents, and nobody but surgeons are going to be thinking about regional therapy, regional delivery of treatment. So I really feel like this is a field that we need to move forward with innovative trials, innovative agents such as the vaccinia virus, oncolytic virus therapy. So in summary, surgical oncology is an important piece of the cancer treatment team requiring specialized training and experience. The Society of Surgical Oncology in the United States is a dynamic global community of cancer surgeons shaping advancements in the profession to deliver the highest quality surgical care for cancer patients. And as surgical oncologists, we need to improve care for our patients with focused research efforts. And while you may have different goals than I think it's important to define those goals as we have here and really try to achieve those goals through focused research and mentorship and education, and really get to where our surgical techniques are refined such that the patients are having the best possible outcomes. So I will stop there and look forward to a question and answer period.
Hi, I'd like to thank Professor Bartlett for a really excellent and insightful talk. So I'd like to invite audience on site as well as those who are online to ask the questions. And while people are thinking about their questions, maybe I'll ask the first question to Professor Bartlett. So as I said, I'm a medical oncologist. I'm actually quite intrigued with what you have said about this relationship between surgical oncology and medical oncology advances. Do you think that the relationship and the communication between the medical oncology community and the surgical oncology community is good enough, or how could we improve that? Because obviously there may be some key advances in surgical oncology or vice versa in medical oncology that impact on the patients, but are we communicating those advances sufficiently to each other?
I think that we are communicating well. I think the biggest point that I wanted to bring forward is that although that most of the good research is being done on the medical oncology side, and but surgery is such an important part of the cancer treatment paradigm that we really need to advance surgical principles and surgical research as well. And so, I really truly don't fault the communication issues, but this is more kind of just a call to arms of the surgical community to say, hey, we need to do better as surgical oncologists to really focus on the things that we need to improve upon, because the medical oncologists are not going to think about those things, and the research that they do is going to be more focused on systemic therapy.
Thank you. I believe we have a question from the floor. Yes, go ahead.
Thank you, Professor Bartlett. This was a very enlightening talk on the moonshots for surgical oncology. What are your views on another moonshot about equity and access to the healthcare, as well as decreasing the variability in offering the innovations to patients?
I think that's extremely important. That we, if you look at on a global scale, for sure, providing access and state-of-the-art and innovative care to everyone with cancer is certainly an important thing for us to strive for. So I agree that would be an important moonshot as well. And I did not talk really about global care so much and access to care and those kind of things, but that's extremely important.
Okay, Jimmy, go ahead.
Thanks, David. Thanks for the wonderful lectures. Jimmy So from Singapore. I'm a surgical oncologist, but I think our setting is a bit different from your institute. Therefore, my question is more administrative. And we are in the university tertiary hospital where we have the conventional divisions based on the anatomy. We have colorectal surgery departments, hepatobiliary surgery department. So compared to your setting where a comprehensive cancer center, we're just treating cancer cases, we also have benign or elective or emergency surgery. So how do we put inside the context of this subspecialty department versus surgical oncology in a comprehensive cancer center?
I think this is a big challenge, and I did notice as I traveled kind of around the world as part of my SSO presidency that this is an issue that's extremely common in, I would say, most countries, that the field of surgery is dominated by organ-based subspecialties and not so much disease-based specialties like surgical oncology. And in some ways, I feel that in the United States, we just got off on the right foot because we had leaders in surgery that were surgical oncologists and came out of comprehensive cancer centers. And this really, strengthened this specialty and allowed us to be the umbrella organization. Now, that being said, I have thought a lot about how do you integrate complex general surgical oncology into a department of surgery. And the truth is that we do things a little differently. And so while state-of-the-art or standard rectal cancer might be the realm of the colorectal surgeon, recurrent rectal cancer, metastatic rectal cancer, just as an example, peritoneal-based disease, regional therapies, infusional therapy, pumps, these kinds of things may not be pushed forward by the colorectal subspecialist, but are important elements of what a complex general surgical oncologist does. So when I look at how we fit in, we as surgical oncologists end up being very busy, even in a world where it's dominated by subspecialists. I also think that we have a certain responsibility for our patients and are not handing off the patients to medical oncology once we've done our operations. We really take responsibility of the care of that patient from start to finish, working with the medical oncologist. So it's a little bit of a different atmosphere as well that the surgical oncologist has. So I do think there's room for surgical oncology as a separate division within surgery and can coexist with these subspecialties.
Okay, we have another question from the floor.
Hi, David. I enjoyed your talk. I'm Melissa Teo. I used to be the head of surgical oncology at the National Cancer Center in Singapore, and actually have been attending the SSO meetings for 15 consecutive years since I graduated from the Toronto Surgical Oncology program. I mean, I think a lot of what you said is critical, and I do obviously see a role for surgical oncologists, but as Jimmy mentioned earlier, it has been a struggle in Singapore. I think we have gone one full circle in that sense. And one example is surgical oncology as a division and a department, and in fact as a team that I led at the National Cancer Center previously, was one of the postings that surgical residents used to have to do in their fourth year, because it allowed them to see the complex surgeries that may not necessarily they may not come across if they were to just do disease or organ type specific postings. Unfortunately, at one of our health classes, that surgical oncology posting has been taken away in that sense, and they rotate through that posting as a junior resident, really just to be impressed upon them that it is but another just tenet of general surgery. So the question I have is not so much how important surgical oncology is, because I think a lot of the people who are listening to this conference are convinced of its role, but how would you suggest that we in Singapore, for example, navigate the administrators, the health authorities, to be able to see that? And I mean, I've emphasized, for example, surgical oncologists going through the programs and understanding how multidisciplinary care is so critical and important, and the interaction with our medical and radiation oncologists cannot be underemphasized. But, I fight sometimes the surgical giants who feel, that surgeons are the only thing that matter in the treatment of cancer, and that they should have first rights, and that's about it. And we don't have that coordinated approach. But even for people who understand that, it's difficult to see and convince them of the role of surgical oncologists. I'd like to hear your thoughts on this.
Yeah, and I don't obviously understand all the infrastructures that you deal with in terms of developing subspecialties or specialties. But one thing that I think was very, very important in the United States was the establishment of specific training programs in surgical oncology. And not only establishing those programs, but moving them forward into a board certification. And I don't know if that's feasible in Singapore or if it exists, and I apologize because I probably should know. But that really solidifies us, because what happened is all of, I would say 90% of the general surgery trainees in the United States want to specialize. And once surgical oncology came on board as a board specialty, it became very popular and it became very competitive. And so right now in the United States, it's one of the most competitive fellowships. And so what that means is the best and the brightest are going into surgical oncology. They're staying in surgical oncology. They're participating in our meetings and building this subspecialty for the future. And that's to me the hurdle that you have to start with, is making sure that it's a very competitive training program so that you can grow it from the bottom up.
Thank you, Professor Bartlett.